In this video, we will deal with the drugs acting on the sympathetic nervous system. In previous videos, we discussed that the adrenergic drugs may be classified in 5 different ways. Firstly, they may be classified into catecholamines and others. They may be classified on the basis of their selectivity into non-selective and selective drugs. They may be classified on the basis of their indications. They may also be classified on the basis of the targets at which they bind. And finally, they may be classified on the basis of the actions that they produce. Now, as we discuss the drugs acting on the sympathetic nervous system, we will try to follow the order in which the drugs are classified according to their indications. As such, we have the vasopressors, which come first, the adrenergic vasopressors, and we start off with the drug Midodrine. Midodrine is a drug which is useful for orthostatic hypotension. It may be used when other non-pharmacological measures and deprescribing measures have failed, and other drugs used in orthostatic hypotension include a drug known as fludrocortisone. This is a drug that we shall learn more about when we learn about glucocorticoids. The next vasopressor, the next adrenergic vasopressor is ephedrine. Now, this substance is derived from a plant known as the ma huang plant or ephedra. It is important because it is probably the only truly mixed acting adrenergic drug. It is the vasopressor of choice in pregnant females with hypotension without cardiac arrest, and it is also a good choice in the setting of hypotension associated with anesthesia. Tachyphylaxis, or the rapid development of tolerance, is a feature of ephedrine. And of course, we know that tolerance is a situation where an effect previously produced by a given dose of a drug can now be achieved only with a higher dose of the same drug. Now, moving on to adrenergic inotropic agents. Now, pharmacological doses of catecholamines have important roles to play in critical care. These catecholamines include epinephrine, norepinephrine, dopamine, and dobutamine. Now, the use of these catecholamines become very important in the management of various forms of shock. Shock, we defined this term in previous videos, and we loosely defined shock as a state in which there is acutely diminished cardiac output or reduced effective circulating blood volume, which impairs tissue perfusion and leads to cellular hypoxia. Now, there are many ways in which shock can be classified. One common way in which shock is classified is into this scheme, whereby shock is classified into distributive shock, hypovolemic shock, obstructive shock, and cardiogenic shock. Distributive shock, in turn, is classified into septic, anaphylactic, neurogenic, and other forms of shock. Now, in general, norepinephrine is considered to be the first-line inotropic agent or vasopressor agent in the management of shock. But if we consider anaphylactic shock, then the drug of choice is well and truly epinephrine. So in other forms of shock, when we use norepinephrine, this may be followed by other vasopressor agents or inotropic agents like dobutamine or dopamine. Let's now begin with epinephrine. The uses or indications of epinephrine may be discussed under 2 headings. Number 1, indications of epinephrine in critical care, and number 2, other indications. Now, as far as the indications of epinephrine goes in critical care, there are 2 very important situations where epinephrine is head and shoulders above all other drugs as the drug of choice, and that is anaphylactic shock and cardiac arrest. It may also be used in other forms of shock which have failed to respond to other first-line drugs. It may be used in acute exacerbations of bronchial asthma which has failed to respond to other first-line drugs. But classically, when we learn about drugs used in bronchial asthma, we do not see epinephrine as one of the drugs which is included in the classification. But yes, it can be used in acute exacerbations of asthma which has failed to respond to the other drugs. Epinephrine may also be used in acute decompensated heart failure which has failed to respond to other first-line drugs, and there are other situations where epinephrine finds use. But by far the two most important uses would be anaphylactic shock and cardiac arrest. There are other situations where epinephrine is used. These include situations where it is used together with local anesthetic agents, in spite of the fact that epinephrine has no local anesthetic effect whatsoever. Epinephrine is also classically described as having a role to play in the treatment of glaucoma, although this is a very limited indication of epinephrine, and we shall see why. Epinephrine can reduce aqueous formation, and it does augment uveoscleral outflow, and therefore it can reduce the intraocular pressure. But the problem with epinephrine is that it very poorly penetrates the cornea, and therefore topical applications of epinephrine are generally considered a very poor choice in the treatment of glaucoma. Finally, epinephrine can also be used in the treatment of epistaxis. So regarding the indications of epinephrine in critical care, epinephrine is well and truly the drug of choice for anaphylactic shock and for cardiac arrest. We need to know that there are different solutions of epinephrine which are available for different indications. Now, the two most important solutions which are available include a 1 in 1000 solution and a 1 in 10,000 solution. A 1 in 1000 solution is also called a 0.1% solution. It is also described as a 1 milligram per ml solution. So this particular solution of epinephrine is indicated in anaphylactic shock. In adults, we give a dose of up to 0.5 ml, and the route of administration is classically intramuscular, and the site of choice will be the anterolateral aspect of the thigh. When we talk about a 1 in 10,000 solution, what we are actually talking about is a 0.01% solution of epinephrine, which can also be described as a 0.1 mg per ml solution. Now, this particular solution is indicated in cardiac arrest. Now, here we require a larger volume of the drug. We need up to 10 ml of the drug. And classically, this is administered as an IV bolus. Now, to make a solution of 1 in 10,000 epinephrine, what we do is we take a 1:1000 solution ampule of epinephrine. This ampule would have a total content of 1 ml of solution. We draw this 1 ml of epinephrine in a 10 ml syringe, and we draw 9 ml of normal saline in this same syringe. The solution thus obtained is 10 ml of 1 in 10,000 strength of epinephrine, and this is what we use in the treatment of cardiac arrest. Now, what is the rationale of using epinephrine in anaphylactic shock? Well, we know that histamine receptors are located in the bronchi, in the smooth muscles of the bronchi, and upon stimulation, they cause bronchoconstriction. We also know that beta-2 receptors are present in the smooth muscles of the bronchi, and upon stimulation by epinephrine, it causes bronchodilation. This is a classical example of functional or physiological antagonism. And this becomes one of the reasons why epinephrine is the drug of choice in anaphylactic shock. We should also know that because of alpha-1 stimulation, epinephrine is able to treat the fall in the blood pressure. It reduces mucosal edema and reduces membrane leakage. Because of the intense vasoconstriction that it produces, it will reduce capillary leakage and therefore reduces mucosal edema and membrane leakage. Unlike norepinephrine, epinephrine has activity on beta-2 receptors. This causes the bronchodilation that it produces and is capable of controlling mediator release. For example, it controls the release of mediators of anaphylactic shock such as histamine and so on. Yes, so we have discussed the use of epinephrine in critical care. Now we move on to the use of epinephrine with local anesthetic agents. We need to clearly understand that epinephrine by itself has no local anesthetic effect whatsoever. However, it is often combined with local anesthetic agents, and we need to know why. Now, epinephrine produces vasoconstriction. This will prevent any co-administered local anesthetic agent from escaping into systemic circulation. The net effect is that there will be a prolonged local action for the local anesthetic agent. In fact, the duration of action can be approximately doubled. There is greater efficacy of the local anesthetic agent, and since we are using a lower dose of the local anesthetic agent, there is less likelihood of toxic effects of the local anesthetic agent. So that's why we combine epinephrine with local anesthetic agents. Having said that, we need to be very cognizant about the fact that epinephrine containing solutions should never be injected into tissues supplied by end arteries. The resulting vasoconstriction can cause gangrene. So we need to know which sites should be avoided. Now these include the fingers, toes, the ears, the nose, and the penis. So these are the areas where epinephrine containing local anesthetic agent solutions should be avoided. We discussed about the role of epinephrine in glaucoma. We spoke about the fact that it reduces aqueous formation and augments uveoscleral outflow, but because it has very poor corneal penetration and causes ocular smarting or burning, it's a poor choice. A prodrug of epinephrine exists by the name of dipivefrin. It penetrates the cornea and is hydrolyzed by esterases present in the eye into epinephrine. But even then, dipivefrin produces significant ocular stinging and other unpleasant adverse effects, and therefore it too is not a very popular choice. Okay, now we need to move on to understand what the effects of epinephrine are on the systolic BP, diastolic BP, and heart rate when given to humans as a continuous IV infusion. And we need to know the effects of epinephrine on the mean blood pressure when given in experimental animals. So what are the effects of epinephrine on the systolic BP, the diastolic BP, and heart rate when given as slow IV infusions? We know that epinephrine produces a rise in the systolic blood pressure, a fall in the diastolic blood pressure, and a modest increase in the heart rate. The effect of epinephrine on the mean BP is different. It is described as the biphasic response. Now, there are two experiments conducted with epinephrine which are of great historical importance in pharmacology, and they include the biphasic response and the vasomotor reversal of Dale. These particular experiments were conducted in anesthetized animals. Now, when epinephrine is injected intravenously into an anesthetized animal, the mean blood pressure rises rapidly to a peak and then falls below the baseline and finally returns to baseline. This is called the biphasic response. Now, initially, larger concentrations of epinephrine were available, and larger concentrations of epinephrine can activate alpha receptors. And the result is an elevation in the blood pressure. But as adrenaline gets eliminated and its concentration falls, it is no longer capable of stimulating alpha 1 receptors, but still capable of stimulating beta 2 receptors. This results in vasodilation and a consequent fall in the blood pressure. So this is how it would be represented diagrammatically. Now, if the black line represents the baseline, this would be how the graph would look. As you can see, there is a biphasic representation over here with an initial peak caused by alpha 1 stimulation and subsequently a trough, which is explained by beta 2 stimulation. Now, this same experiment may be repeated in the exact same manner, but only this time the anesthetized cat is pre-treated with a drug that blocks alpha receptors. So the cat is treated with an alpha blocker, or rather it is pre-treated with an alpha blocker. In this situation, epinephrine cannot stimulate the alpha receptors. It will stimulate only the beta 2 receptors, and therefore the rise in BP doesn't happen. And what we observe is only a fall in the blood pressure, followed by a return to the baseline. So this is how the graph would look like. And this phenomenon is referred to as the vasomotor reversal of Dale. In other words, when epinephrine is injected intravenously into an anesthetized animal that has been pre-treated with an alpha blocker, the blood pressure does not rise rapidly to a peak. Instead, it falls below the initial level or the baseline and then returns to the baseline. Now, moving on to the adverse effects of epinephrine. Well, extravasation of epinephrine will cause necrosis and sloughing. So if such a phenomenon occurs, then we should promptly treat such a situation by infiltrating the affected area with phentolamine, which is a non-selective and reversible alpha blocker. Now we move on to norepinephrine. Now we know the effects of norepinephrine on systolic BP, diastolic BP and heart rate. We know that norepinephrine produces a rise in the systolic BP. We know that norepinephrine has no effect or negligible effect on beta 2 receptors, and therefore even the diastolic BP rises, and this corresponds to a fall in the heart rate. We have also discussed that norepinephrine is considered the initial vasopressor of choice in many forms of shock. These are some of the indications of norepinephrine. And let's move on now to dopamine. Dopamine is used for the treatment of various forms of shock in critical care. As we discussed, the effect of dopamine on the vasculature varies according to the dose at which dopamine is administered. In low doses, defined as up to 5 micrograms per kilogram per minute, dopamine causes vasodilatation via stimulation of dopaminergic receptors. At intermediate doses, namely 5 to 10 micrograms per kilogram per minute, Dopamine stimulates beta 1 adrenergic receptors, thereby improving cardiac output. At higher doses, that is to say more than 10 micrograms per kilogram per minute, the alpha adrenergic effects dominate, causing peripheral vasoconstriction as well as vasoconstriction of the mesenteric and renal vascular beds. It is worth noting at this point that dopamine does not cross the blood-brain barrier and therefore cannot be used as such in the treatment of Parkinson's disease. We use a prodrug of dopamine. We call it levodopa. And levodopa makes use of transporters in the blood-brain barrier and enters the brain, where it gets converted to dopamine and becomes useful in the treatment of Parkinson's disease. And this will be dealt with separately in drugs used in the treatment of Parkinson's disease. Now, regarding Dobutamine, again, this is a drug which is used in the various forms of shock. It increases the cardiac output and stroke volume, and it does so usually without a marked change in the heart rate. Dobutamine causes vasodilation. Okay, so now we move on to the adrenergic tocolytics. A tocolytic is something that is going to inhibit contractions of the uterus, and as such they can be used to temporarily arrest preterm labor and delay childbirth. Tocolytics have beneficial effect on perinatal outcomes by allowing more time for fetal maturation, allowing time for administration of antenatal corticosteroids, which are of enormous importance in accelerating fetal lung maturation. It also gives us time to facilitate in utero transfer of the pregnant lady to a higher level of care where such complicated pregnancies may be managed. It is true that in the past, adrenergic drugs such as Midodrine were considered the agents of choice as tocolytic agents, but in recent years, their use has been significantly declining due to both maternal and fetal side effects. It has been found that these adrenergic tocolytics can lead to complications such as pulmonary edema, myocardial ischemia, and cardiac arrhythmias. Therefore, at the time of recording, the most common tocolytic agents used for the treatment of preterm labor are nifedipine, indomethacin, and magnesium sulfate. And among these, nifedipine is considered to be the drug of choice. We discussed about the role of non-selective alpha agonists in glaucoma. Now we need to also discuss briefly the effects of selective alpha-2 agonists in the management of glaucoma, and these drugs will include Clonidine and brimonidine. Again, these drugs act by reducing the production of aqueous humor and increasing uveoscleral outflow. Now we move on to adrenergic Mydriatics. Anticholinergic drugs are considered as cycloplegics and Mydriatics. Now, they can be used to dilate the pupil in order to view the fundus, and this is what we call fundoscopy or fundoscopy. Alpha-1 agonists, on the other hand, like phenylephrine, produce pure mydriasis without cycloplegia. 2.5% phenylephrine is used in combination with a short-acting anticholinergic drug like tropicamide for routine dilatation of the eye, of the pupil rather. However, anticholinergic agents, especially atropine, can precipitate an attack of acute congestive glaucoma in predisposed patients, and this is especially true in elderly patients. So if we need to perform a fundoscopy in an elderly patient, it is best to completely avoid anticholinergic drugs. Phenylephrine alone at a concentration of 10% may be used safely and efficaciously as a mydriatic. Moving on to the adrenergic antiarrhythmic drugs, isoproterenol. Now we know that isoproterenol acts on both beta 1 and beta 2 receptors. It can cause an increase in the systolic BP, a fall in the diastolic BP, and a marked increase in the heart rate. Now, because isoproterenol causes a significant increase in myocardial oxygen demand, its use is very restricted. It is used in refractory cardiac arrhythmias such as Torsades de Pons, which ends up being refractory, and temporary control of refractory symptomatic bradycardia. Okay, so now we move on finally to the adrenergic drugs used as antihypertensives. Now, in general, adrenergic drugs are considered as drugs that ultimately increase the blood pressure. In fact, we began this discussion by talking about vasopressor agents, inotropic agents. Epinephrine, norepinephrine, dopamine, and dobutamine are examples of such drugs. They can be used in situations when the blood pressure is dangerously low. However, there are adrenergic drugs that bind selectively to alpha 2 receptors and which stimulate these receptors. The end result of such stimulation would be a decrease in the release of endogenous catecholamines. Hence, instead of increasing sympathetic activity, these adrenergic agonists actually produce sympatholytic or sympathoplegic effects. The result is vasodilatation and therefore a fall in the blood pressure. Some of these drugs are very useful as antihypertensive agents, and they include Clonidine and alpha-methyldopa. Clonidine is an alpha-2 agonist. It binds selectively to the alpha-2 receptors and stimulates these receptors. The end result is a decrease in the release of endogenous catecholamines, and hence instead of increasing sympathetic activity, Clonidine actually produces a sympatholytic or a sympathoplegic effect. The result is vasodilatation and therefore a fall in the blood pressure. Clonidine has some other unique uses as well. It is useful when administered epidurally with other opioid analgesics. It is useful in the treatment of withdrawal symptoms precipitated by opioid withdrawal. It is useful in the treatment of diarrhea in patients with autonomic neuropathy, and there are plenty of other off-label uses for Clonidine. Now, one important thing that we need to remember about Clonidine is that it is available in both oral and patch form, and the patch form is referred to as the Clonidine transdermal therapeutic system. This system allows slow and continuous delivery of Clonidine over a prolonged period of time, typically a week or so. So this would be the stratum corneum of the skin, which has got good blood supply. The reservoir of Clonidine would contain the drug either in solution or bound to a polymer. It has an occlusive backing membrane and a micropore membrane which can release the drug at a constant rate. An adhesive layer ensures that the transdermal patch sticks properly to the skin. When we buy or purchase the transdermal patch, the adhesive layer is protected by a film which can be peeled off prior to application on the skin. Now we need to remember that Clonidine should never be stopped abruptly. There are two reasons for this. Number one, it will precipitate withdrawal symptoms, and number two, there can be rebound hypertension. The sort of withdrawal symptoms that we can expect after sudden withdrawal of Clonidine would be headache, apprehension, tremors, abdominal pain, and sweating with tachycardia. Now, it is important that we also know how to manage a situation where there is rebound hypertension due to clonidine withdrawal. If there is absence of life-threatening end organ damage, then the easiest thing to do would be to restart clonidine. If more rapid control in blood pressure is required, then what we do is we give the patient nitroprusside or labetalol and try to control the hypertensive crisis. It is true that in the past, phentolamine was considered the drug of choice for rebound hypertension due to clonidine withdrawal, but currently its role in the treatment of rebound hypertension due to clonidine withdrawal has been relegated because the evidence regarding the safety and efficacy of phentolamine with regard to this indication is sorely lacking. Finally, we move on to Methyldopa. Now, Methyldopa is important because it is the drug of choice for control of mild to moderate hypertension in pregnancy. It has the best documented maternal and fetal safety record. During long-term use in pregnancy, Methyldopa doesn't alter maternal cardiac output or blood flow to the uterus or kidneys. But in non-pregnant ladies, Methyldopa is not at all popular because we have far more effective and better agents. To have a clear idea of how Methyldopa works, we need to refresh our memory regarding the synthesis of catecholamines. We know that the site of synthesis of norepinephrine is the sympathetic nerve terminal, and that it begins with the uptake of tyrosine into the sympathetic nerve terminal. Tyrosine is acted upon by tyrosine hydroxylase and gets converted to dopa. Dopa gets acted upon by dopa decarboxylase and gets converted to dopamine. Dopamine is stored into storage vesicles where it is converted into norepinephrine, and when this nerve gets stimulated, norepinephrine is released. Now, what happens when we administer Methyldopa? Methyldopa is a prodrug. Now, normally, dopa decarboxylase would convert dopa to dopamine. But in the presence of Methyldopa, dopa decarboxylase will convert alpha-methyldopa to alpha-methyldopamine. And alpha-methyldopamine gets converted to alpha-methyl norepinephrine. Alpha-methyl-norepinephrine is the pharmacologically active metabolite. It gets stored in secretory vesicles of the adrenergic neurons, and when the adrenergic neuron gets stimulated, it will secrete alpha-methyl-norepinephrine instead of norepinephrine. Alpha-methyl-norepinephrine stimulates alpha-2 receptors and inhibits further release of catecholamines, and therefore the net effect is a sympatholytic or a sympathoplegic effect, and ultimately a fall in the blood pressure. Here. So, Methyldopa is considered as an inhibitor of dopa decarboxylase. It prevents dopa decarboxylase from performing its normal physiological action. Regarding alpha-methyldopa, the most well-known adverse effect is autoimmune-mediated hemolytic anemia.